Grand rounds. We'll go ahead and get started with a few announcements. So our next grand rounds will be December 16th. Our speaker will be Dr. Emily McCann, and she's going to be talking to us about compassion fatigue. Our next journal club will be December 9th, and that will be led by Lauren Cohen and Jeff Wallace. Following today's grand rounds, you will receive an email with a link to the recording of today's presentation, as well as a copy of the slides. There will also be included with that email a link to an online evaluation. So if you could please take a few minutes to fill that out, we would really appreciate it. Please feel free to submit questions in the chat or Q&A boxes anytime during this presentation. And we'll get to those either during the presentation or at the end. So I'm really pleased to introduce our speaker this morning, Dr. Micol Rothman. Dr. Rothman completed undergraduate training at Brown University and then received her MD degree from Columbia College of Physicians and Surgeons. She did her internship and residency at Johns Hopkins and then came to the University of Colorado for her fellowship in endocrinology, diabetes, and metabolism, where she stayed on as faculty since 2006. She's currently a professor of medicine in the Division of Endocrinology, with secondary appointments in psychiatry and radiology. She's director of the Metabolic Bone Clinical Program and co-founder of the UC Health Integrated Transgender Program. She reads bone densities also for the University of Colorado Hospital. Her research interests are in the intersection of sex steroids and metabolic bone disease. So we're just thrilled to have her here today to speak with us about hot topics in osteoporosis. So welcome, Dr. Rothman.
Thank you. Thanks so much, Carrie. And thanks to everyone. This is an esteemed group that I know knows a lot about osteoporosis. So I'm hoping to share some new things with you and also let you know a little bit about what's been going on here at CU. We've got some programs in place that you may or may not be familiar with. So I hope to also have this opportunity to share some things that are happening, which are harder to do these days since we don't all see each other as much. Can everyone see my slides?
Yes.
Okay, great. All right, I have no disclosures related to this talk. And as mentioned, I want to talk a bit about risk assessment. I think sometimes we don't always think about the risk of our patients. And I would say this is kind of an, emerging area in osteoporosis to really try to think about treating the high risk patient versus the low risk patient differently. So we'll talk a lot about risk. I want to talk about treatment discontinuation. This is also a hot topic. So it covers bisphosphonate holidays, some concerns about Denosumab, which I know is used a fair amount in the geriatric population. So talk about when treatment discontinuation is appropriate, which agents, how to do it. And then, as mentioned, I'd like to talk about some of our local programs and how they can help with fracture assessment, post-fracture care, and also help for inform osteoporosis treatment. So I'm going to do that with 3 cases. The first will be a 74-year-old man who presents with hip fracture. The second will be a 70-year-old woman who's been treated with Denosumab for 6 years. And the third will be a 65-year-old woman who has osteopenia on a screening bone density. So we're kind of going to start with the highest risk patients and work our way down, if you will. So as mentioned, there's been a lot of attention recently to really thinking more about risk. And I'm going to show this slide a couple of times in a few different contexts. And I want to give credit to Mike Lewicki, as this was put together as part of a talk we did for Endocrine Society. And it kind of meshes the Endocrine Society guidelines as well as the ACE guidelines, which again really have tried to address this question of fracture risk. And the idea is that our lowest risk patients, so those with normal T-scores, no fractures, low risk, really can be treated with non-pharmacologic therapy. When we start to think about the moderate risk patients, and we'll talk about FRAX and some of those implications a bit. So the patients with osteopenia who haven't fractured, who are overall deemed low risk, kind of when do we think about non-pharmacologic therapy? Perhaps we think about a bisphosphonate. And then as we move on to the higher risk patients, then we're really saying that these patients need to be treated with pharmacologic therapy. So really anyone with a fracture, anyone who's high risk, even if their bone density is in the osteopenia threshold, these are really folks we should be thinking about treating. And then here's kind of the fork into this very high risk. And the Endocrine Society and ACE guidelines differ slightly in their wording, but I think the sentiment is the same, is that in the very high risk patients, we really need to be thinking about anabolic agents. And I'll show you some data that really show that treating with anabolic agents first line in very high risk patients really may be the way to go. So with that, let's turn to our first case. So this is a 75-year-old man who's got a history of coronary disease and Parkinson's and an unsteady gait. He falls in the parking lot and breaks his hip. He's admitted to the hospital, undergoes repair. The hospital stay is complicated by delirium, atrial fibrillation. He's discharged to rehabilitation, comes in for follow-up accompanied by his daughter. She's concerned about coming back to live by himself, wants to talk about options, and osteoporosis is not discussed. And I put this here as our first case because I think this happens a lot, and I'll show you some data to back up that statement. And I think we are all familiar, and I think certainly as the geriatricians in the audience are familiar with the impact that a hip fracture can have on someone's independence, on the whole family, on someone's life going forward. And what we really see is that in all of these things and these transitions and complicated hospital stays and new medications, the osteoporosis often gets lost in the shuffle. And what we're really left with is a crisis in the treatment of osteoporosis. So we've got 2 million fractures occurring in the US each year, and this was represented a few years ago by this mound of casts that was traveling across the country. 50% of women over age 50 who will have an osteoporotic fracture. And mortality post-hip fracture is about 20% and actually higher in men than in women. Only 40% of patients with hip fracture fully regain that pre-fracture level of independence. And I think that's what we're seeing in this patient and that we see in our patients. But also even vertebral fractures and silent vertebral fractures predict future fractures. We know that men, particularly with hip fracture, and again, this is a group I know that's at the VA where fortunately you can get more screening bone density for men. And you'll say this is old data, but unfortunately I'll show you that it's still true. Men have a higher mortality after hip fracture and are also undertreated. So again, this is old data, but looking at men and women after hip fracture at discharge, again, the rates are pretty abysmal all around for the women as well. Less than 20% really being treated with any agents at all, and really pretty much none in the men. And you may say, oh, well, you know, Micol, that's 2002 data, but unfortunately, we're really not doing much better. And if anything, medication use after hip fracture is trending down since 2002. And there's really some concerns, as mentioned, that this has really created a crisis in osteoporosis. And there's lots of questions about why. We'll talk about medication fears. I think this idea of osteoporosis getting lost in the shuffle. Again, I'll show you some of our local data where we've really tried to delve into this question. But the rates really seem to stick to this kind of 20% when you look across studies in people being treated after hip fracture. And some of it is this idea of connecting the osteoporosis to the fracture. So you hear this from patients, right? So this was a guy, this patient in our index case here fell in the parking lot. Well, I mean, and who hasn't heard from patients? You should have seen how icy the parking lot was. You know, anyone would have broken a hip. I fell really hard. I got tangled up in my oxygen. I just tripped. And I think what we really need to make sure that we're imparting to our patients is this is osteoporosis. A normal bone should not break with a fall from a standing height. And if you are tuning out and don't hear anything else that I say for the rest of this talk, just remember a normal bone should not break with a fall from a standing height. And it really doesn't matter how icy the parking lot was, all of these things, a normal bone should not break with a fall from a standing height. So there are concerns about this connecting the osteoporosis to the fracture. And this is a study from 2017 where they surveyed 634 women, 93% of whom had post-fracture contact with their PCP. So again, these are not necessarily hip fractures, but other fractures, people who went in after the fracture to see their primary care provider, 73% indicated that the PCP knew about the fracture. But in 63%, osteoporosis management was discussed. 55% fracture prevention was discussed, but 31% still said their main source of osteoporosis information was from the media, and less than 20% thought that the osteoporosis caused their fracture. So although we're getting a hint that maybe we're doing a little better, again, knowing that the point of this appointment was probably to talk about fracture care, and you still have a third of patients where it's really not even being addressed at all, and they're not necessarily even getting osteoporosis treatment in an appointment designed to talk about fracture. And again, connecting the fall. I put a couple of these references here. I think this hip fracture JAMA piece is actually a really nice kind of short, great reference. And also some the recent task force, and then a task force from the ASBMR. And again, there's this disconnect between connecting the fall to osteoporosis to the fracture. So a third of people over age 65 fall each year. Up to 15% of falls will result in fracture. 90% of hip fractures happen from a fall from a standing height. And, you know, the concerns are that we have our older patients on medications that can make falls potentially worse. So thinking about the medications in our older patients, diuretics, antipsychotics, benzodiazepines, opioids, and then thinking about fall clinic referrals. Now, the fall clinic at the university has been, I think, a little bit up in the air more recently, but it's definitely an effort to have a multidisciplinary clinic with a geriatrician, PT, OT, and really assess our patients for falls. And this recent USPF task force that I highlighted here really talks about falls and not necessarily supplementing vitamin D to prevent falls, but really, thinking about people who should be offered multifactorial interventions to prevent falls. So exercise is a big part of this. We'll talk about that. We talk to our patients about balance, core, strength training. And I think these are all really important interventions to talk to people about, hopefully before fracture, but certainly after as well. So again, let's go back to our risk stratification and think about this gentleman. So this is a man who hasn't had a bone density. And again, remember, bone density is not routinely covered for men under Medicare. I know that at the VA, you are able to get bone density for men, but that's not generally true outside of the VA system. And so even without knowing his T-score, we already know that based on his hip fracture, he's going to be either at high risk or very high risk, and he should be treated for his osteoporosis. So how do we think about osteoporosis treatment? So I just want to delve into that, and then we'll come back to this patient. So when we think about our osteoporosis agents, they're really in two classes. And there's the agents that act on bone formation that we call the anabolic agents or osteoanabolic agents, and the agents that act on bone resorption, which are our anti-resorptive agents. And as we think about bone biology, obviously this is simplified. I know there's many of you in the audience who research in this area, but we think about the osteoclasts kind of coming in and chomping out old bone, and then our osteoblasts coming in and filling in new bone. Our osteocytes as really the mechanosensing receptors of the bone, really sensing that stretch. I tell patients they like to be knocked around. That's what exercise does, is it stimulates osteocytes to make factors that then influence osteoblasts and osteoclasts. But as we think about our bone forming agents, kind of, bluntly put, these agents are going to increase osteoblasts in various ways. And as we think about our bone resorptive agents, anti-resorptive agents, they're going to really kind of put the kibosh on the osteoclasts, either for a longer term period or a shorter term period. But essentially, that's how these agents work. I will talk a little bit about our newest kid on the block, Denosumab, and I put it here kind of in the middle because although it is a really potent bone forming agent, it also has a little bit of anti-resorptive action as well. So it's a little bit really of both. It's kind of our first dual agent that has both anabolic and anti-resorptive properties, whereas some of our other anabolics that we think about stimulate bone formation, but they do also stimulate bone resorption to a lesser degree. So this is kind of when we're thinking about a patient like this who is high risk, who we are going to treat with a pharmacologic therapy. These are kind of what comes to mind is, are we going to choose a bone forming agent? Are we going to choose a bone resorpting agent? And again, I would argue that the most important point is that we choose something. In some ways, maybe less of what we choose, although there's data for multiple agents. So again, this is a bit of a busy slide, but I'd like you to have it really kind of more for reference as we talk to patients about the anti-resorptive agents and then the more anabolic agents. What are we thinking about? So our first line, kind of most widely available, is going to be our oral bisphosphonates, which you're all familiar with. They can be daily, they can be weekly, they can be monthly. They're widely available, they're inexpensive. What are their disadvantages in terms of the oral agents? We worry about esophagitis. We tell patients to take these with a big glass of water first thing in the morning, empty stomach. They can be a little finicky with their absorption. We do sometimes see joint aches. And there are these rare but serious side effects of osteonecrosis of the jaw and atypical femoral fractures. Atypical femoral fractures really more associated with long-term use. Osteonecrosis of the jaw typically occurs after an extraction, more common in the higher dose agents used for cancer and those kinds of things. But we do talk to every patient about it, also because they will hear about it from others. So I think it's always best if they hear about it from us. There are issues in terms of EGFR creatinine clearance that we get into with some of these medications. So that can be a limiting factor, particularly I think in our older patients. There's the IV bisphosphonates. Do remember that there are some IV agents approved every 3 months, but you're going to be most familiar with zoledronic acid, which is once a year. Great agent. It's there. There's no issues of compliance. Once it's in, you avoid the oral side effects. It does tend to have more reactions up front. So you will see in about 25% of patients flu-like symptoms, typically lasting about 48 hours, occasionally longer than that, and potentially, again, here some musculoskeletal symptoms. There's Denosumab, which is our rank ligand inhibitor, subcutaneous every 6 months. Its kind of niche is no renal adjustment needed. In some of the early studies, there were some concerns about skin reactions and skin infections, hypocalcemia, and as we'll talk about, the concerns for rapid bone loss. Again, any of the anti-resorptive agents have been associated with these rare but serious side effects of osteonecrosis of the jaw or atypical fractures. Then we get into our anabolic agents. These are given daily subcutaneously, 18 to 24 months, although the black box warning for teriparatide has now been removed, so you can use for longer in select patients. Their advantages is really this anabolic action, really very potent, particularly at the spine, particularly for patients with glucocorticoid osteoporosis. I'll show you some of the data that really do show that giving these agents to patients who are treatment naive up front really can have some advantages. Nausea, cramping, hypercalcemia are the main things we worry about. There are still some concerns. Really, this is not borne out over time. Teriparatide has been on the market now for almost 20 years, and they really haven't seen the signal for osteosarcoma. But recall that in the studies that got it approved, there was a signal in juvenile rats for increased risk of osteosarcoma. So we don't use it in people generally who have risk factors for osteosarcoma, such as radiation therapy or unfused epiphyses or unexplained elevated alkaline phosphatase, Paget's disease, those kinds of things. Abaloparatide has now been out for a few years. This is a PTHrP analog, potentially less hypercalcemia. I would not say we're seeing fewer side effects at all. Honestly, I think we're seeing as many, if not more, side effects in terms of just the general kind of aches, pains, palpitations, headaches with abaloparatide. I will note that abaloparatide is not FDA approved for men. I am aware that it's available at the VA, but just so that you all know, outside of the VA, it is not actually FDA approved for men at this time. Romosozumab, as I talked about, is now our sclerostin inhibitor that is given subcutaneously for every month for 12 months. And as mentioned, it has a bit of a dual anabolic and anti-resorptive. There have been concerns from one trial about an increased risk of cardiovascular events. So it is not to be used in anyone who's had a recent cardiovascular event. And again, because there is this dual anti-resorptive and anabolic, there were a couple of cases of ONJ, atypical femoral fractures, in the studies. And again, just really kind of for your reference, I just want to point out what's been studied in terms of vertebral and non-vertebral fracture data, talk a bit about cost. I think we do need to think about cost. The oral bisphosphonates, again, generally going to really be the least expensive. They've really got great fracture efficacy. Again, IV zoledronic acid and denosumab, fracture efficacy at all the sites. although the anabolics don't have documented hip fracture efficacy, some of this may be related to needing larger numbers, and that studies weren't all powered necessarily to detect that. But I do note that they don't actually have that data, and same as well with romosozumab. So I want to talk a little bit about IV zoledronic acid, because this is actually one of the studies we have that includes men, which is not, we don't actually have as much data on men as women in this area. And this was a study where they gave IV zoledronic acid after hip fracture. So one could argue this could potentially be a great choice for the patient that I mentioned. And they saw a decrease in fracture, but also notably a decrease in mortality. And the mortality was not all fracture related. So that's definitely been something of interest for a long time. Sometimes we get into questions about exactly when to give it. We don't necessarily give it in the hospital, but we do try to give it soon after ensuring that calcium and vitamin D have been repleted. And I do also just want to point out, when we're really thinking about high-risk people, that there are a number of trials now that do show that the anabolics are superior to the antiresorptive agents in very high-risk patients. So as mentioned, we have some data that shows that teriparatide is superior to alendronate in glucocorticoid-induced osteoporosis with decreased vertebral fractures. We have the Vero trial that showed teriparatide superior to risedronate in women with compression fractures. So again, high-risk patients. This was the ARCH trial that looked at romosozumab versus alendronate. And then there was a second year where everyone was on alendronate, decreased fractures and severe osteoporosis. Again, I'm sorry, this is the Vero trial that showed teriparatide superior to risedronate. So I'm not saying that all patients need to be treated with anabolics, but I think it is important to know, and particularly too, I will use these trials when trying to justify to insurance that may not want to cover an anabolic first line for a patient, particularly for patients after vertebral compression fracture. I think there really are some compelling data to treat patients with anabolics first. So with that, I want to tell you about a tool. Again, I don't know if everyone has access to EPIC through the university, but something that's happening here is this agile pathway that you may have heard about with diabetes or other disease states. And this is an EPIC integrated flow chart that's really supposed to help you guide in evidence-based care, to help you choose an agent and think about which agent is right for your patients. And there's a number of different ones, but I want to tell you a little bit about the osteoporosis one. Laura Mackey in internal medicine and Lisa Schilling also have really been the champions of this and really trying to help develop this rollout for primary care. And the idea is that it makes the ordering easy. It kind of gives you a evidence-based way of thinking about choosing agents, and also really helps you navigate EPIC, which can be another challenge. So this is what the osteoporosis one looks like. And so basically, when this is live, you can click on all these things. So this will link you to clinical guidelines. This can link you to decision-making tools, calculators such as FRAX, and really helps kind of define what people are talking about. And you can actually click through and order things like a secondary workup. So again, here, okay, and this is also really designed to be used if you get a bone density back and see that the patient has osteoporosis and are trying to decide what to do. So does the patient have osteoporosis, which is defined by either a low T-score or a fragility fracture or an elevated FRAX? And then you would move over to this column. You can order a bone density, you can order secondary workup. Again, if the patient is in the osteopenic range, it'll sort of take you through all of the agents there. And you can actually give feedback on these tools now, and we're actually reviewing them every 6 months and trying to keep them updated. So if you want to know where this is, it's actually in the Pathways tab. And I will point out that there's actually a lot of other helpful pathways as well. So there's osteoporosis initial, and then we also have an osteoporosis subsequent, where you can, if someone's been treated for a few years and you're reassessing, there's diabetes as well, and abnormal liver function and other workups. So I really, I want to congratulate Dr. Mackey. I think this has been a huge, a really big success to really try to help guide people when guidelines can be confusing and EPIC can be confusing. So with that, I want to go back to our case. So let's just say it went a different way. So what if this 75-year-old man with a history of CAD and Parkinson's, unsteady gait, fell in a parking lot and broke his hip? And what if he got admitted to the hospital and the osteoporosis was talked about then? So let's change this story a little bit. So what are we doing here to try to make this happen? So in 2014, we implemented a comprehensive hip fracture protocol. And I want to give a shout out to Mary Anderson Wallace, who's a hospitalist who's not with the university anymore, Jason Stoneback in orthopedics, and Kelly McDevitt, orthopedic nurse at the time. And what they developed was this comprehensive hip fracture protocol. I don't know if this happened to you all when you were a resident, but when I was an internal medicine resident and a hip fracture patient would come in, there would be this like big fight that ensued between ortho and medicine. Where was the patient going? And the patient would be sitting there in the ER while the ortho and the medicine residents were arguing about where the patient would go. And apparently that happened other places too, such as here. So at the university hospital now here at Anschutz, all patients are admitted to orthopedics with a medicine consult. And there are order sets in place for pre and post management. So I'm just going to talk about the osteoporosis, but I do want to point out that there's also streamlined orders for DVT prophylaxis, for pain control, other measures that's trying to prevent the delirium, such as what our patient had. We draw basic labs in terms of osteoporosis, so just really a CMP and a vitamin D, and a bisphosphonate is initiated if there's no contraindications. And when that came out, we looked at pre-intervention and post-intervention. And again, I don't think this is just because of the osteoporosis, but some of the other factors that I told you about, they actually saw a decreased length of stay that was clinically significant. So that's compelling. Certainly, we saw a huge change in terms of people who were discharged on osteoporosis therapy. Now, I will tell you the one-year data that tailed off a bit, but certainly a significant number of patients who were discharged on therapy. And then also higher incidence of follow-up to bone clinic, PCP, orthopedics clinic. We've really tried to get this more to PCPs now at this point. So I think this intervention has really been powerful and effective. And we then actually looked afterwards, after a year of the program, and we actually saw a post-intervention higher overall survival versus pre-intervention. So that's a pretty powerful outcome. So I would say our hip fracture protocol has really been successful in that regard. So what else can we do? What else do hospitals do? There's also a concept of fracture liaison services that you may or may not have heard of, which our hip fracture protocol doesn't really quite qualify as that. It's really just more of an order set. But there's also an entity called a fracture liaison service. And the idea here is having an individual champion or a team of champions who identify patients who fractured, look at metabolic bone status, institute medical therapy as indicated. And this isn't necessarily hip fracture. This can be any low trauma fracture. I'm going to show you a little bit of data on the different types of fracture liaison services. So just know that A is kind of the most aggressive and D is the least aggressive. So it can kind of vary. So there can be kind of the least interventional services that just sort of tell the patient, like, you've had this fracture, you need to intervene. There's groups that tell the PCP. There's groups that identify and refer, kind of do a little bit more aggressive treatment. And then there's the most interventional, where the fracture liaison service actually initiates the osteoporosis treatment. And when you look at studies, you'll note that kind of the more interventional, the higher the rates of treatment. But really, fracture liaison services across the board can increase prescription of bisphosphonates and hopefully utility of bisphosphonates. So here, again, these are a number of randomized controlled trials, some retrospective trials, but again, showing really increased rates of, even with just reminding the PCP to talk about osteoporosis. Again, we would argue there could be some room to go here, 22% versus 7%. But again, these agents are really kind of making a difference. So I would, the C and D, kind of the ones that just tell the patient or just tell people, don't tend to do quite as much as the A's and B's, which I think really tend to increase treatment more. And again, where the fracture liaison service is initiating the treatment, then you can really see this is where you can really get rates up into the 80%, sometimes lower. But that's where you're really seeing some of the big differences is if they're actually initiating. And again, I will show you a meta-analysis in case you don't believe me that this is effective, that really looked at rates of, again, this is pre and post FLS versus non-FLS teams. Rates of bone density treatments are higher, rates of treatment initiation are higher, adherence, and then also, again, some compelling evidence against refracture, which is what we're all trying to prevent, as well as mortality. So having some kind of fracture liaison service in place can really be helpful. So what do we do here? We started in 2017, and this is through ambulatory health promotion. Seniors Clinic is a part of this. And any of the UC Health or CU Medicine, I should say, sorry, CU Medicine PCP sites. And those are already, ambulatory health promotion already does some screening for them. But anyone who's admitted to the hospital here, we're trying to branch out to some of the other UC Health hospitals, and anyone who's seen in the emergency room with a low trauma fracture, fall from a standing height. And we arrange for PCP follow-up, laboratory testing, DEXA testing is organized for the patient. And then the idea is that the focus of that visit is on osteoporosis. So how well does it work? So when we initiated this is kind of 2016, before we started any of this, again, not surprisingly, compared to the historical data I showed you, we were kind of sitting here at around 20%, just like the literature I showed you. You see that the hip is really the best in terms of treatment initiation. And I think a lot of that is because of our hip fracture protocol. So a lot of these patients are admitted to the hospital, started on therapy at the time of their inpatient stay. And you can see that's when you can really get these numbers up until kind of 60, 80%. This is all fractures, so this includes hip and non-hip. And you can see here that that's sort of in the middle. And then when we get to the non-hip fractures, we're still, maybe we're doing a little better now, but we're still kind of, at that 40 to 50% mark. So again, this is getting the patients to have blood work, have a bone density if appropriate, and setting up a PC appointment to talk about osteoporosis. And when the appointment is made, they say, this is a visit to talk about osteoporosis. We've made some little tweaks along the way. So the ambulatory health promotion team, sometimes their notes were getting ignored. So here we kind of moved it so that it would be a little bit harder to miss. Maybe that caused an uptick for a little while, hard to say. Then now the clinical pharmacists have been involved in forwarding the notes to them. Hopefully, maybe we're seeing a little bit of an uptick from there. So we tweak this pathway periodically as we look at our data and try to see what we can do to intervene. So why are we only at 50%, you may be asking? So we've looked at that. So what happens? So here's the people who don't get prescribed. So let's delve into, again, our institution, the half of people who aren't being prescribed. So even with, kind of like the first patient I showed you, even though the appointment is designed to talk about osteoporosis, a lot of times it doesn't get talked about. Patients miss the appointment. They no-show, they cancel, they don't make the appointment. Okay, what if osteoporosis is talked about at the appointment? Does it still get prescribed? A lot of times, no. So it can be discussed, it can be ordered, it can be never administered. Patient can refuse, although honestly, this is a lower amount than I would have thought. I would have thought we would have a lot more refusals, and we actually don't. There's a bisphosphonate contraindication, so then nothing else gets ordered. If something else gets ordered, then that would count in the other half. So these are people who have bisphosphonate contraindications, but then nothing else necessarily gets ordered. Normal T-score, I want to delve into that a little bit, and then also just no reason. So it just doesn't get talked about, or it does get talked about, but nothing ever happens. So what about this normal T-score? So we also kind of delve into this because, again, I think there's still some concern that even if a patient has a fracture from a standing height, perhaps they don't really have osteoporosis. However, when we looked at the T-scores of people who don't have medications, some of them don't have a bone density ordered, but a lot of them actually do have bone densities that show T-scores in the osteoporotic range. So you would argue even if they hadn't fractured, you would be treating this. Oh, and I don't know if I said this is only patients 65 and up. So that's the whole intervention is only 65 and up. And again, plenty of them certainly in the osteopenia range with a fracture. So there's really only a small segment of them that have a normal bone density. And, to justify that that's kind of not why they're being prescribed. And we can argue about the patient with normal bone density and whether they should be prescribed treatment or not. But again, a lot of it is still just the osteoporosis getting lost in the shuffle of other things, I think is really kind of the takeaway here. So with that, I'll kind of close case one. I don't know if we want to do any questions right now, or do you want to hold off, Carrie?
So there are a couple questions if you want to take them now.
Sure.
The one is whether are there data on liaison services that initiate bisphosphonate infusion therapy in the hospital?
Yeah, there are some that do. There's been a lot of pushback on that, both so the orthopedic folks tend to push back on giving IV bisphosphonates in the hospital initially because it wasn't covered, like as with DRGs and that kind of thing. They also worry a bit about the acute phase reaction. So someone's post-op, they get an IV bisphosphonate, they get a low-grade fever, that's going to set back the hospitalization. So there hasn't been a lot of enthusiasm for doing it in the hospital. In the trial that I showed you, I think they typically did it about 2 to 6 weeks after hospitalization. And that has been more the norm. So I don't know of any particular, but obviously it's a really attractive option because it would be in and done, and you would know that your patient is treated.
Thanks. A couple other questions if we have time for them now. What's the role of monitoring DEXA during treatment? Do you use it to guide treatment changes if BMD does not increase as desired?
Yeah. And so I think here, no change in bone density is actually good. Everyone loses a little bit of bone each year. So if you're not losing, even if you're maintaining, I think that's a success. I think it depends a little bit on the patient, but we do expect to see maintenance or increase in bone density typically with an agent. And I think sometimes we have to think about other factors, whether we change therapy or not, but it's certainly one of the things we take into account, consider a change in therapy for sure. So I would do one typically 1 to 2 years after initiating.
And then last question in right now, for treatment naive patients who have 2+ compression fractures, would you favor an anabolic agent? And do you think it's best for endo to see and manage these patients on anabolics versus PCPs should be able to start and monitor these agents?
Yeah, I think I definitely in that situation would favor an anabolic agent. And again, I think we really do have the data now to support that. I think it depends on the PCP. Just on Monday, I saw someone who had a hard time getting into us. I know, sorry, but the PCP did start, and the patient was already 6 months into therapy when I saw them, and that was great. So I think it depends on the PCP, and I think certain people. I mean, I know over in the seniors clinic, you all have a lot of expertise in osteoporosis, and many of you have been using these agents for a long time, and I think that's great. So I don't think there's any reason that a PCP couldn't do it if they feel comfortable with it.
Thank you. All right, that's all the questions for now.
All right, so let's talk about going off medications. So this is a 70-year-old woman with osteoporosis who's been treated with Denosumab for 6 years, no fractures, normal GFR, and her bone density has gone up, and she now has osteopenia, and she wants to stop treatment, but she's maybe heard, or you've heard, that that might not be such a good idea. So, oops, I lost my, sorry, okay. So I do want to point you to the Endocrine Society guidelines here, which do talk about reassessing risk. And as I mentioned, our Agile pathway also talks about reassessing risk. So we'll just hone in here for the purposes of this on Denosumab and talk about how to stop Denosumab. We can also talk a little bit about how to stop bisphosphonates, but there is this notion that we should be reassessing risk and not just leaving people on agents for the rest of their lives. And the duration kind of depends on the agent. So osteoporosis medications are not all the same. So my first take-home point was a bone should not break from a fall from standing height. My second take-home point is osteoporosis medications are not all the same. So you cannot give a drug holiday from denosumab the way you would from a bisphosphonate. And there's, again, data behind this. I'm just showing you NTX data, which is a marker of bone turnover. But the notion being here is that we know that things like estrogen, right? So this is a patient who's treated with estrogen. Estrogen is stopped, bone turnover goes up. So we know that things like estrogen, calcitriol, when we stop these agents, bone turnover goes up. But we also know that agents like alendronate are different. So when you stop alendronate, bone turnover doesn't go up as abruptly. But when you stop denosumab, again, we knew this when denosumab came out. This is one of the earlier studies of denosumab. This is 24 months of denosumab. You stop denosumab, boom, bone turnover goes up, almost like a rebound effect. Versus something like IV zoledronic acid, which I think of as just the gift that keeps on giving, particularly, and I don't say that lightly. I mean, during COVID, initial lockdown, we were so worried about all these people on denosumab. No one wanted to come into the hospital, but the people who had IV zoledronic acid, we didn't worry, right? So we know that after 3 years of IV zoledronic acid, followed by 3 years of placebo, there's very little difference between 3 on, 3 off, and 6 years on. So I essentially never treat anyone with more than 3 years of IV zoledronic acid in a row. And look at the serum CTX, they just stay suppressed. So these agents are not all the same. And we learned this, unfortunately, with some case reports of severe rebound vertebral fractures, multiple vertebral fractures happening in people who had discontinued denosumab. And so this came out a few years ago, and there's been a lot of interest in sort of figuring out how to transition off denosumab if we transition off denosumab, but there's no drug holiday. So one of the ideas has been to use IV zoledronic acid, and I'll show you some of the data here, looking at changes in bone density in terms of who's kind of at risk for this rebound and how do we attenuate it. So the people who do seem to be at higher risk are the people who've been on denosumab for longer. So this patient, having been on it for 6 years, is at higher risk of a rebound than if she had only gotten a couple of doses. The ones who had prior vertebral fractures before they ever started also are at higher risk. And then again, those who had been on treatment longer, those who are younger age, lower BMI, do seem to have a higher degree of bone loss associated. That said, giving zoledronic acid is associated with a fewer number of fractures. So there's been a lot of interest in sort of how do we discontinue it. I thought this was a great review that really kind of helps guide. So as we think about a patient who wants to come off denosumab, so let's say they're a young patient at low risk, they say you maybe wouldn't have wanted to choose this agent in the first place. If they've used it for a couple years, but their overall risk is low, then you could think about an oral bisphosphonate for a year or two, or think about IV Zol for a year or two. There can be some help in reassessing bone turnover markers, and some have advocated for using a serum CTX in this situation. If it's still high, you would give another dose. What about someone on long duration, like this patient? So you certainly can continue it. You can continue denosumab indefinitely. And I do have a number of patients that's what we're going to do. They maybe have compromised renal function. They maybe didn't tolerate other agents. And there's nothing to say that you can't continue it for more than 10 years. That's just how long it's been studied. If you want to go off, then this is kind of their suggestion in terms of how to do it. So switching to IV zoledronic acid, starting at 6 months, and then looking at bone turnover markers. And if you're really seeing increased bone turnover markers, we can argue about exactly what that number looks like. Is it 300? Is it more like 600? But if they really are increased after 3 or 6 months, maybe considering a second dose of IV zoledronic acid at 6 or 12 months, even if you're not checking bone turnover markers. Also, you can use oral bisphosphonates. There was a question initially as to whether oral might be better in this situation, because as the denosumab is coming off, maybe if you were giving these small doses of oral repeatedly, that could be more helpful than just giving one shot of Zol if maybe the bone turnover wasn't high enough to take it up. But the data since then have suggested that zoledronic acid may be better actually than oral bisphosphonates. So that's kind of how to get off denosumab. I don't see any new questions right now, so I'll go to the third one and then we can do questions at the end. So again, this is also just to talk a little bit more about screening and non-pharmacologic therapy. So a 65-year-old woman who gets a screening bone density, lowest T-score minus 2.3, are we going to treat her? So again, I just want to bring up this concept of risk. So this patient would be, well, we don't know, right? Because we don't know her FRAX, but this is going to be someone who's either at low risk or moderate risk. And I would argue that we should really be thinking about someone like this differently than we were thinking about our first gentleman, and really thinking about low risk versus high risk patients. So how do we decide who to treat? There are a number of calculators and guidelines. Most of you are probably familiar with the NOF guidelines that would recommend looking at FRAX in a patient like this. And if her 10-year fracture risk was more than 20% for a major osteoporotic fracture, or more than 3% for a hip fracture, that we would initiate therapy. And there are other risk calculators, but FRAX is probably the most commonly used. And again, whether we treat her is going to vary, right? So if she's 65, her lowest T-score is minus 2.3, she has no other risk factors, then no, we probably wouldn't treat her. But if she had a parental history of hip fracture, if she had current tobacco use, then we're seeing indications that her fracture risk would go up. If she was older, just by nature of being 75 with the same T-score versus being 65, then we would indicate treatment. So I think FRAX can still be helpful to help us think about the patient with osteopenia and to help us look at more than just the T-score. And of course, that's not a perfect tool. There are issues with consistency. You may have noticed if you put in a young patient with a very low T-score, their fracture risk is low, but that may be a patient you wait and you don't treat right away. We don't have a lot of good data about treating patients with higher bone density. That's not who our trials are done in. They're not done in 85-year-olds with lowest T-scores of minus 1.3. So we don't have a ton of data. We would assume that the agents would be effective. FRAX doesn't weigh all the factors. So we know that more steroids for longer is worse than short course of steroids for shorter, but the FRAX is kind of a binary, yes, no. There are definitely other risk factors included. So there's a Garvin calculator that includes falls. FRAX does not include falls. And of course, it's all on hip, not on spine. So lastly, just to say a word about calcium and vitamin D, there's really mixed data here. Calcium and vitamin D are given in all the trials. My take home point on this would be that these are threshold vitamins. So we know that when people are severely deficient in vitamin D and calcium, if we get them back to, a normal level, there's improvement. Is there really improvement beyond that? I think we really don't know. And I think that's part of why there's been so much conflicting data in calcium and vitamin D, is that many of the trials took people who were sufficient and gave them more and didn't get a benefit. But when you look at some of the trials like elderly nursing home patients not getting sunlight, those are the populations that really do seem to benefit. So these are threshold vitamins. You've got to get to a certain level, but more is not necessarily better. Lastly, I just show you the IOM recommendations on calcium and vitamin D. Again, we can kind of argue about these. What we tell patients in the bone clinic is to really try to get their calcium from the diet if possible. There's never been studies that show harm from dietary calcium. I think some of the cardiovascular concerns are really based on supplemental calcium. In terms of vitamin D, again, there's lots of different arguments here. And then, but basically, 2,000 units really has not ever been shown to cause any kind of toxicity. That's typically what we still aim for in the bone clinic. And we really do try to keep levels typically above 30, recognizing that there's going to be some flux probably over the course of the year. Lastly, I do just want to say a word about exercise. As mentioned, weight-bearing exercise is really what we're trying to get patients to do, but can't forget about muscle strengthening. We know that muscle talks to bone. We know that sarcopenia is a big player here as well. Balance exercise, fall prevention, posture, again, all of those things are going to be key. So in our patient with the osteopenia, again, when we're focusing on non-pharmacologic therapy, there really is a lot still to talk about here. And, we didn't really talk about discontinuing tobacco use, alcohol, again, all of those lifestyle measures that we're going to do. So in conclusion, I hope I've convinced you that osteoporosis remains under-recognized and under-treated. A bone should not break from a fall from a standing height, and really hoping to think a little bit more about fracture risk. And I think there's some tools now to really help us think about high-risk patients versus low-risk patients, and that not everyone with the same T-score is the same. Considering anabolic therapy in your highest risk patients, considering holding off on therapy in your lowest risk patients, really making that individual assessment. And then lastly, drug holidays are only for bisphosphonates. With that, I just want to acknowledge that we've got so many members of our metabolic bone team. As I mentioned, the comprehensive geriatric hip fracture program and all the champions there, our fracture liaison service run by Ambulatory Health Promotion, Alex Marcus, who does an amazing job with all of this, and our pharmacy, PharmD, Sarah Billups, who's responsible for the data that I showed you, who collates that data. Our metabolic bone team, of course, Dr. McDermott, West, who, even though he's retired, he still comes to Bone Conference, so I'm not taking him off the slide. Dr. Swanson, Dr. Elsheikh is one of our newest bone providers. Our orthopedics team they've really been champions in terms of osteoporosis, and we appreciate them. And also the Agile Pathways, and Sai, who's also now, I think, over at the VA, but has a wonderful knowledge in terms of osteoporosis agents. So with that, I will stop sharing and would be happy to take questions.
All right, thank you so much. So a few questions coming in here. So first of all, with regard to risk factors, are other hematological diseases as highly associated with osteoporosis as is RA?
So I think the RA, we kind of sometimes use that almost as like a surrogate for inflammation. So, and actually Sterling West used to always talk about this too. I think if someone has inflammatory bowel disease or some other inflammatory state, you can really plug that in as a yes. So I don't know if it's necessarily hematologic disease, but I would say anything with where we know there's a lot of inflammation, that's probably really negatively impacting the bone.
All right, and then question about if you're monitoring bone turnover markers after starting a treatment holiday, any reason to prefer either spot urine and telopeptide versus serum CTX?
Yeah, I would say we've really moved towards serum CTX now just because it's easier. We do it morning fasting, and I really do try to do it that way if I'm going to use it to guide treatment decisions. So morning fasting CTX, I would say, is the best.
And then how and when do you consider resuming therapy after a bisphosphonate drug holiday?
Yeah, I think it's looking at a number of factors. I mean, certainly if someone fractures, if bone density is significantly declining, and or serum CTX is significantly increasing, kind of weighing all of those factors, I would say.
Question about borderline creatinine clearance where bisphosphonates can't be used, which is very common in older folks. Can they be used in those cases where people are kind of borderline?
Yeah, I see that Sai is here, and I guess I don't know if we can unmute him, but he just recently looked at, and I don't want to get this wrong, so I believe it was patients over 75, right, with lower creatinine clearance, and then he looked at patients getting particularly IV zoledronic acid. And Sai, please forgive me if I'm saying that not exactly right, but basically really trying to look at this question of older patients who we know with borderline creatinine clearance and really didn't see any concerns in terms of renal function. So, I think we tend to try to use oral more than IV. There certainly were patients when, Paul Miller did a retrospective where they looked back at some of the oral bisphosphonate trials, and there clearly were people who had certainly stage 4 CKD who were included in those trials and didn't seem to have untoward effects in terms of renal function. So there may be a little bit more give there. So I would say use cautiously. try to hydrate well. I mean, honestly, I've had issues with the infusion center, kicking back those orders to me, which is, I think, part of why Sai did this retrospective study. So I don't know, maybe he can comment in the chat.
I'll look for that. All right, how about should frequency of DEXA monitoring on drug holiday every 2 years?
I think that's fair. I mean, again, I guess it still depends on the patient. So if this is someone who you think probably didn't need to be treated in the first place and their bone density is great, would you do it longer? Sure. I mean, I think you do have to individualize it. I think it's really thinking about the risk of the patient and how long you think it's going to take for them to cross a threshold until you would think about retreating. So this is someone who you thought was maybe higher risk initially, you're going to be a little bit more, you're going to have a little more scrutiny there. You're going to be a little bit more on it versus someone who you think, okay, this person's probably, doesn't have a family history of osteoporosis. This is not going to be a problem for them. Oh, here it is. Okay, yes. So 500 doses of zoledronic acid, adults 75 and up. Okay, good. Yeah, the rate of AKI after infusion was the same as for the randomized trials. So I think, some reassurance about treating some of our older patients who have received, and a lot of our older patients, just when you calculate creatinine clearance, which is what was used in the trials, none of them qualify for IV zoledronic acid, which is why we wanted to take a look at that. Right. And there were 25 patients who had creatinine clearance less than 35, which again would be kicked out by the infusion center. And none of them had any renal issues. Thanks, Sai. The AFib, yeah, that was a question. So Jeff Walsh just asked about AFib after IV Zol. That there was that one trial paper a few years ago that raised that. And I don't know that we've heard too much about that. I do mention it. I mean, I have certainly, with common things being common, I have had people with AFib that I've treated with IV zoledronic acid. I don't think it's a contraindication, but there were some concerns that there was a higher risk and it hasn't completely borne out.
Any other questions? I don't see any more coming in. Well, thank you everybody for participating. Please take a moment to look at the email and fill out an evaluation. And Dr. Rothman, thank you so much. This was just a really fabulous talk. So thank you for joining us this morning.
Great.